And I want to show you a very simple case just to go through the procedure step by step. So this is the clinical case. It's a 73-year-old man who has hypertension and dyslipidemia, and whose past medical history is characterized by two heart surgery intervention, a mitral valve repair, and then a mitral valve replacement with the bioprosthesis for endocarditis. He has permanent AFib with 3 strokes. And so he was referred, and this is another kind of indication, he was referred for LAA closure after recurrent strokes on different anticoagulant regimens, so both with direct anticoagulants and warfarin. So this is the procedural planning. We started with a CT scan. This is a standard CT scan, and we could measure the LAA. You can see there is the right image where there is the circumflex artery right here, and here is the ostium of the LAA. We can take 2 measures here, the biggest and the smallest diameter of the LAA. And also we can anticipate which will be the projection in which we will work during fluoroscopy, and this is RAO caudal, like in most cases. And also here we can identify the fossa ovalis in order to select the proper point of the fossa ovalis where to do the transeptal puncture, which is usually, like in this case, in the inferior part of the fossa ovalis, in order to be very coaxial with our guiding catheter to go into the LAA. So this is the setting and the procedural plan. We do this kind of interventions under general anesthesia with transesophageal guidance. We take a right femoral access, and we have a continuous blood pressure monitoring through the radial artery. And these are the steps we will go through in the next slides. So starting from the femoral vein access, we want this procedure to be safe, so we do echo guidance, echo-guided femoral vein access, and we insert the ProGlide. So this is the septal puncture, and this is the transesophageal view. We start coming down from the superior vena cava, and we try to identify the correct spot, because it is very important to lose some time in order to find the correct spot for the transeptal puncture. And here you can see that the needle is the inferior part of the fossa ovalis. Then we move to the short axis, where we can clearly see the aorta in the anterior part of the heart, and we can puncture correctly in the center or a little bit posterior in the fossa ovalis. And after that, we can give heparin, a full dose of anticoagulation for the whole procedure. Then it is very important also to assess the position of our stiff guide wire, because we need to advance all the material on a stiff guide wire, and this stiff guide wire has to be in the left upper pulmonary vein to be the safest way. And here you can see in this nice image, there is the bioprosthesis, there is the LAA, and there is this stiff wire that goes through the atrium into the left upper pulmonary vein. Now it's time for the true seal, which is the guide catheter, which is a 15 French sheath, actually, to go through the septum. And again, transesophageal echo is very important in order to monitor the passage of the guiding catheter through the septum and towards the left upper pulmonary vein. And at this point, we need to engage the LAA. So to do this in the safest way, we need to put a pigtail inside the true sheath, advance our pigtail under fluoroscopy, and check under echo the correct position of the pigtail inside the LAA. So here you can see that the pigtail is going through the LAA, and you can see the binary of the pigtail at the tip of the LAA. And so on this pigtail, we can advance by pushing a little bit and rotating clockwise and counterclockwise our true sheath in a very safe way up to the LAA. And again, you have a nice transesophageal echo image that shows the correct trajectory of the guiding catheter towards the center line of the LAA and up to the tip, to the distal edge of the LAA. So at this point, it is very important, before choosing the device, to have a good LA pressure. So to correct size the device, we need to have an LA pressure which is higher than 10 millimeters of mercury, and in this case we measured 15 millimeters of mercury, so this was okay. And at this point we can select again some measures with the echo, which was 25 millimeters per 24 millimeters in this projection, And also we did an angiogram. This is the RAO caudal view that I showed you before on the CT scan, and this is the LAA opacification with contrast. You see the pigtail, the guiding catheter, and the opacification of the LAA. And again, we can take some measurements also in fluoroscopy. So in this case, we had all measurements, both from CT scan, echo, and fluoroscopy that showed an LAA ostium between 24 and 27 millimeters. So by going to the sizing charts, we could select one of the biggest ones, so the 31 or 35 millimeters device, and we selected the 35 millimeter device. As you can see here, it is in the lower part of the sizing chart of the 35 millimeter device. And so this is the device implant. You can see here under fluoroscopy, we were able to advance our device, and it is very important in this part to check the echo to be in the very anterior part of the LAA, like in this case. You can see there is the flex ball that I will show you later in the next slide. You can see there is a small ball. Here is the device that is coming out from the guiding catheter, and then you will see that by retracting very slowly the guiding catheter, we can leave the device take his final shape, and being sure that all the LAA is filled with the device. And here you can see that the device is correctly seated into the LAA. You have to push a little bit for 10 seconds on the delivery cable in order to leave the device accommodate itself inside the LAA, and then the procedure is almost done. This is what I was telling you. There is this small ball that is the first part of the release, which is, since the device is completely closed, is very atraumatic, and you can move the device inside the LAA in a very safe way. Again, we need to be sure that the device is stable, so we do the tuck test, just pulling the device and leaving it so the device is stable, it stays inside the LAA. And at this point, we can measure the compression. Here you can see that by echo, we could measure 25 millimeters of compression, so it's more than 30% compression, which is pretty good. So the device has met the stability assessment proof. And again, we check that there is no flow inside the LAA. So this is the color Doppler. You can see that the LAA is completely occluded and there is no leak inside the LAA. So at this point, we can release the device just by unscrewing the delivery cable. You can see by the echo that the delivery cable is unscrewed and the device is in its final and definitive position. And again, if we want, it's not mandatory, we can also do some contrast, inject some contrast in order to have also a final angiogram that again shows a complete sealing of the LAA. And so the procedure at this point is almost done. We just need to check and to rule out pericardial effusion. This is important after the procedure to have your echocardiographer check for pericardial effusion. And then we can remove all the stuff from the heart and from the patient, and the procedure is over. So this is the conclusion of the case. The procedural time was 28 minutes with 24 cc of contrast dye and 10,000 units of unfractioned heparin. The patient had an uneventful hospital stay and was discharged the next day, and the follow-up TOE is planned in 3 months. And he was discharged on warfarin and aspirin, plus beta blockers and antihypertensive drugs. So thank you so much.